I'm Michael Wexler, Professor of Medicine and Director of the Asthma Program, Co-Director of the Cohen Family National Jewish Asthma Institute in Denver, Colorado. There are approximately 30 million patients with asthma in the United States, and 10 to 15% of those are felt to have severe refractory asthma that warrants therapy beyond inhaled corticosteroids and long-acting beta agonists. These patients often have daily symptoms. They have frequent exacerbations requiring prednisone. They miss work, they miss school, and there are many patients, in fact, 2 million emergency room visits for asthma every year, 500,000 hospitalizations for asthma every year. Asthma is a very heterogeneous disease, and when a patient suffers from an asthma attack, there's a few things that are going on. One is bronchoconstriction, or narrowing of the airway smooth muscle around the airways. Another is significant inflammation that also causes narrowing of the airways. At the tissue level, what's going on is there's cellular infiltrates from mast cells, from eosinophils, that may release their mediators into the airway tissue, causing inflammation, causing the narrowing, and being manifest as either chest tightening, cough, or wheeze, or with airway hyperresponsiveness or twitchiness of the airways. Mast cells are long-living cells that live in the tissue of the airways and other areas that are associated with asthma pathogenesis. Stem cell factor and its receptor, known as KIT, a tyrosine kinase receptor, are important for mast cell development and survival. Targeting the mast cell and targeting KIT, we hypothesize, may result in significant improvement in airway hyperreactivity and also in terms of asthma pathogenesis. Imatinib, also known as Gleevec, is a tyrosine kinase inhibitor that's used in chronic myelogenous leukemia as well as in other diseases to inhibit mast cell activity. This study was a proof of concept 24-week double-blind placebo-controlled study in which we gave imatinib versus placebo to patients with severe refractory asthma. A bronchoscopy was done at the beginning and at the end of the study to assess for tissue effects of the imatinib, and we also did methacholine challenges to assess for airway hyperreactivity, both at the beginning of the study as well as at the end of the study. The primary outcome of the study was a measurement of airway hyperresponsiveness. There were 62 patients who were randomized in this study, and methacholine challenges were performed at the beginning and at the end of the study. And what we found was that imatinib-treated patients were able to have a 1.7 time doubling dose of their methacholine challenge, or their PC20, versus just a 1.1 time fold doubling dose of their methacholine challenge PC20. This results in a significant improvement in airway hyperresponsiveness in these patients. Accompanying these findings was the fact that we also identified a significant reduction in mast cell tryptase levels in the tissue of these patients with severe asthma. We know that tryptase is an enzyme that is associated with airway hyperresponsiveness and asthma pathogenesis. So reducing tryptase, accompanied by improving airway hyperresponsiveness, is a significant finding in this patient population. Although the study wasn't powered to examine other outcomes, we also observed that imatinib resulted in some statistically non-significant improvements in lung function, asthma control, and asthma symptoms, which are all clinically meaningful outcomes. Airway hyperresponsiveness, as measured by methacholine PC20, is also an important outcome and has been associated with asthma exacerbations in other studies. So improving airway hyperresponsiveness is a very important outcome for patients as well. In terms of safety, while there was no significant difference in either the total number or in the number of severe adverse events observed in this study, there were 2 patients who enrolled in the imatinib arm who ended up discontinuing study drug, one due to neutropenia and one due to muscle cramps. These were both thought to be drug-related. The rate of the neutropenia, which I would say is a serious adverse event, was just 1 out of about 30 patients. So the rate is relatively small. However, the efficacy observed from the study, I would say, outweighs the potential risk as long as patients are closely monitored for this and other potential side effects. Based on the findings of this study, I think that there is enough preliminary data to consider doing a larger study that would look at other outcomes important for severe asthma. Such a study would probably be a little bit longer, probably lasting about a year, and examine other outcomes such as asthma exacerbations, which is an important outcome for asthma patients, physicians, as well as for payers.